Just about a year and a month or so ago, we were at Stroon Winery, and Stephen was there, and he said, "You should come to this conference." We were all tasting the new 27000 releases, which was probably the best year that Ontario's had in 25 years. And I said, "No, well, we can't go next weekend. We already have an obligation." He said, "Well, you've got to come." So it was really quite delighted when Ron asked me to come, and then he said, "But you have to speak as well." So, so here I am. So we were getting ready to go, and I've been to Kansas before, and I said to my wife, "We're coming to Kansas." She says, "Kansas? Oh, we have family from Kansas." My she's the real Canadian. She was born and raised in Canada. And so she was looking in the family tree, and I have the name of the town here. It doesn't exist anymore, but it's Joquet, near the Colorado border, was where some of her family members lived before they immigrated to Kansas in the 1800s, right around the time of the Civil War. And my connection to Kansas was my great uncle was actually chair, or at least professor of history at Kansas State University in Manhattan. So that's how we come about. But anyway, let's talk a little bit about IV vitamin C. So what I want to do today is talk a little bit about sort of how it's done in Ontario, what are happening in Ontario, what we're doing at the Teaching College, which is the Canadian College of Naturopathic Medicine in Toronto that Stephen referred to, a little bit of what I do in my practice as well, and then we'll talk about some of the adjunctive therapies that are done with our cancer patients, both at the school and in my practice, roles and theories related to cancer and vitamin C, why vitamin C, and then I want to talk about some research opportunities and needs. Ron said we should ask some questions, so I'm going to try to pose some of those. So let's talk a little bit about regulation in Ontario. I'm a naturopathic doctor, which is a little bit different than a medical doctor. My education was a pre-medical education, and then we had to do 4 years of naturopathic training, and I did mine in Canada. The reason I went to Oregon to get a second one was that in Canada it's a diploma, not a degree, and my wife said, "You need to go to school and do a little finishing." So I went to Oregon and did a second ND there, and then that also got me certified and so forth. So we've been allowed to practice since 1925. We've been allowed to legally do parenteral therapy since 2003. Prior to that, it was done, but it wasn't, I guess it wasn't sanctioned by the board is probably the best way to put it. And what Ontario has created is a whole curriculum around doing that. So we have a 32-hour practical course with practice and examinations and provincial exams. We go over the approved substances, and students, because our training is a little bit different, actually learn to use butterflies and Angiocaz, although under the new regulations, Angiocaz is actually the only thing we can use in Ontario now. Learn to use Angiocaz, and then we have to do a certain amount of continuing education. So over the course of the years since 2003, almost 300 naturopathic doctors in Ontario have been certified to do this course, actually learn to do these techniques and use them in their practices. And there are about a little over 1,000 NDs in the province now. So the Canadian College of Naturopathic Medicine, which was founded in 1978, is in Toronto, and for about the last 5 or 6 years has had what's called a cancer care shift. And these are where the majority of patients who are seen at the college are on the shift. Now, not all patients with cancer are on the shift, but these are there. The purpose of this is to provide primary cancer care for these patients, and secondly, to treat other health concerns that these patients have, because while they're individuals and they have cancer, they have other health problems as well. We also take referrals from NDs within the province, mostly in the Toronto area, who perhaps are not certified to do intravenous therapies, and they can treat they will refer these patients, and we will provide treatment. And we have other individuals who will refer us patients, and we will provide treatment as well. It consists of 2 8-hour shifts per week. These are supervised by naturopathic doctors with experience in treating cancer, a combined experience of about 27 years, and we are a fee-for-service. Public health in Ontario, at least medical MD public health, is all covered by taxpayers' dollars under the socialized medicine. Everything else is fee-for-service, and NDs are no exception in that. So this was a survey that was done through the research department at the Canadian College of Naturopathic Medicine, looking at, from 2007 to 2009, the cancer care shift patients. A total of 213 individual patients were seen. 98 patients were entered into the patient database. Now, what you have to appreciate is that patients are entered in the database by the students. And so if the supervisor isn't sort of leaning over them, or the student doesn't feel the urge, then they don't always get entered. So unfortunately, we don't have a complete database at this point, but that's something we want to correct. with a diagnosis of cancer. So, and then the overlap between patients on other shifts and patients on the cancer care shift turns out to be a total of 38 patients. So there's a lot of patients for which we don't have data yet and which we are in the process of trying to correct. The median age of our patients is 51 to 60 years old with cancer. We have a range, but that's the median age. And you can see, which is very unusual for naturopathic care, we have more men than women on the cancer care shift. Most of our patient population of practicing NDs and throughout the clinic is actually about 30% or less male and 70% or more female. So this is actually quite an interesting shift. The distribution of those patients among the various types of cancer, about 26% are prostate cancer, most of them in the 61 to 70-year-old range, breast cancer for about 18%, colon for 13%, and lung for about 10%, and then 32%, and these are just very small numbers, lymphomas, thyroid, ovarian, testicular, and a variety of other cancers. So I've just listed the ones that are most frequent there. So I borrowed these slides from the research person who made them up, but unfortunately things didn't come through. So this is the, let's see, this, have I got the right end of this? I don't know. Oh, it's just, it's just the stronger laser. Thank you.
That doesn't work either. There we go.
It works on my hand. There it is. Okay. These are the prostate. This is breast. These are colon, lung, and other. Unfortunately, in the translation between IBM and Apple, it didn't work, and so we didn't get that. So that's the distribution. And this is the demographic distribution. You can see the high incidence of prostate here. These are our males in the 61 to 70-year-old category. These are, again, males, prostate here. And then we can see then the others are breast, colon, lung, and other. And unfortunately, in the translation, I lost part of the rest of the graph, which I apologize for. But you can see a high, basically the 50s, the 60s, and the 70s, and actually some of the 40s, are where we're seeing most of the patients that are coming to our clinic for cancer care. The duration of treatment, when we look at the ones who we have in the database, and so this is just from the database, treatments from 1 week, somebody came and just decided not to stick around, to as much as 3 years. So we've actually had some very good patient flow. The mean for most patients is about 7 months. Typical mean number of visits is about 12, and there's quite a range on that. And patients who receive IV therapy obviously come for many more visits. So if you can look at that, you can see that of the 17 of the 38 who were on both sets of databases, 45% came for many more visits. So those who come and get the IV are patients who really stick with the program. I'm going to stop for a minute talking about the IV and talk about other things that we do with these cancer patients, and then I'll go back to the intravenous therapies. So these are some things that when we do a chart analysis on these patients and that are entered in the database, these are other treatments that are given to those patients. So for example, melatonin is typically used in these patients, and you can see that the mean dose is fairly high at 16 milligrams with a range of around 3 or 5 up to 20 milligrams. Part of the reason I think that this is one, the research evidence suggests that this is probably an interesting therapy, and we have ongoing at another location in Ottawa, we have a research trial going on looking at melatonin in lung cancer and trying to get patients at 20 milligrams. So I think this is one of the things that's probably initiated this within the students. A second therapy that is quite high within the database is the use of curcumin extracts. The mean dose there of about 1.9 grams. With a range of up to around 4,000. I'm not sure what the unknown is, so let's just ignore that. That's probably a typo on my part. But that is another therapy that we are using in these patients. Vitamin D, you can see our mean dose is around 3.5 international units, which are range typically of 1 to 5,000. Just an interesting aside, in Ontario with the regulation of health, we're only actually allowed to prescribe 1,000 milligrams, or 1,000 international units as an ND. So that's in the chart, though, however. So we're doing it anyway in support of that. EGCG, which is the epicatechin gallate, which is the extract from green tea, a mean dose here of about 1 gram with ranges up to a little over 2 grams in patients are being prescribed to these cancer patients. We're using fish oil, and I broke it down into EPA, eicosapentaenoic acid, about 2.3 grams, and DHA at about 1.2 grams. And you can see the range goes up to almost 5 grams in these patients. And the other thing that we do, because we're naturopathic doctors, is we do diet. So the mean number of discussions of diet or review of diet diaries with these group of patients is around almost 2 diet diaries per patient, with an average of as high as 5 with some patients. So the patients who are in the clinic longer for more treatments will spend much more time going through the diet. And that's really, although I've put that last because it has a sort of a lower value, this is actually the thing we do first, and then we look at melatonin, curcumin, D, EGCG, fish oil, and other nutrients for these patients. And then I just gave you some references range and sort of summarize the data on which patients in general seem to get these. So the melatonin, over 50% of the patients were receiving melatonin, and they were primarily with lung cancer and breast cancer. Curcumin, again, a little less than 50% of patients, lung cancer and the other cancers primarily. D3, a little less than 50% of patients, primarily with colon and prostate cancer. EGCG, just a little under 50%, primarily in the other cancer categories. Omega-3, just under 50% in the prostate, breast, colon, and lung cancer patients. Diet was over 70% and pretty much in all of the categories of patients, no specific thing. L-glutamine as a supplement in colon cancer, and although I didn't give a summary on that, ranges on that are around 3 to 5 grams up to 3 times a day in those patients. Acupuncture, which is something that naturopathic doctors in Ontario can do, it's within our scope of practice, is primarily used for pain control, and so patients will receive acupuncture either during their IVC or as a separate visit, depending on the particular patient. And then lifestyle modification. This is where we talk about exercise, meditation, yoga, tai chi, and all those other things which we think are extremely important at helping with mindset and helping patients to adjust to their condition. So these are some of the adjunctive therapies and things that we do with some support for that. Other complaints that these patients present with, about 40% complained of problems with sleep, 25% with pain, and about 60% or more complained about things with energy. So these are, they have cancer, but these are other complaints. Often they're related to the cancer and the treatments they're receiving, but they are significant life-affecting factors in these patients. So if we look at the study over this period of time, we have a mean duration of care was around 203.8 days, with a range from 7 to, which is basically a week, up to almost 3 years in patients. Most of the visits were consults initially. About 34% of the patients actually get IV treatment as a range there. And then we do, of course, a certain amount of phone consultations. Because it's a teaching clinic, we don't do very much of that because that has to be supervised. And then the mean on this was about 11.9 visits with a range of 2 to 47. So somebody with 47 visits would have been in for lots of intravenous treatments. And so this just sort of summarizes it with the non-IV patients. Duration of care, you can see it's much longer with the IV patients, more visits, and more total consults with these individual patients. Okay, this is where I practice, which is a little town of Dundas, about 20,000, about 100 kilometers, 62 and a half miles from Toronto. We've been offering, or I have been actually offering care there since '91 after I got my second degree from Portland and they let me come back to Canada. And no, my wife said, "You're coming back." So I've been in Canada since '86 except for that hiatus. But my first exposure was actually when I was a student at what was then known as the Ontario College of Naturopathic Medicine when I had a patient who presented with primary liver cancer. So that was actually my first exposure. And we are, of course, a fee-for-service. I've been doing IV treatment there since about '94 to '95 on patients. And my training includes having the opportunity of spending time with Dr. Alan Gaby when I was a naturopathic student. I spent a week in his practice. And he taught me how to do IVs and Myers on some of the original Dr. Meyer patients. So that was actually quite an experience. I've never forgotten that. Then I did my IV certification through GLECOM, as it was then known, which is now ISOM in '98. I took courses in BC and Oregon, and since 2003 I've been teaching the course that Ontario offers for doctors who do IVs. But the place where I've really learned is from my patients and then attending seminars, conferences, and reading the literature. The patients that I have seen, these are most of the types of cancers that I've seen over the years. So I've chosen not to specialize as a naturopathic doctor, but basically if somebody comes, I will see them and try to provide treatment. So I've seen some very common things like breast and prostate, and I've seen some unusual things like ampulla voter and some rare types of sarcomas which are not so common, or ureter cancers. So quite a variety. When patients come to us in Canada, because healthcare is covered under socialized medicine, they have pretty much been through the mill of everything that medicine will provide, and so they're in advanced stages. Most of the patients I see are in stage 3 or 4. They're not given much hope, or maybe they've been told there's nothing that can be done. So it's a difficult situation. We're facing some pretty serious problems. The treatments that I try to offer are individualized. Some patients will do the IVC. Partly that's a factor of their choice. Partly it's a factor of also having to pay because there is a cost associated with that and not used to paying for that. But it doesn't mean that every patient who comes to see me will get an IV. Diet is essential, and so that is one of the things that all of the patients will get is some counseling about dietary things that we can do. And then things that I will add to the regime of what they're doing may include various botanicals, various nutritional supplements in addition to the diet. I provide homeopathic care for the patients, acupuncture. I can do body work and physical medicine, and I will make referrals then for other things such as cranial sacral therapy, yoga, tai chi, meditation, and various other things which resonate with the patient or which they would like to try. And as long as I think it's not going to hurt them, I will support that because the patient's belief system is very important to their treatment. So at the RSNC, which is the Naturopathic College Clinic in Dundas, what we try to do when we see these patients, particularly if we're going to do IVs on them, is we want an appropriate diagnosis and studies and release of records. There's a real difference between practicing in Dundas and Toronto. In Toronto, usually we can get release of records. So I can get MRIs, CT scans, lab work, and so forth. I practice in Dundas. There is a large cancer clinic in the town next to us in Hamilton, and their policy on this kind of medicine is no. In fact, they harass my patients, is probably the nicest way to put it. And I rarely get a response to a release of records. Most of the time I have to go by what the patients told me. Occasionally I get a lab result released. I have this one patient and they know the nurse, the most of the time background again, and so it will come, the lab result will come, but the name is torn off the top. So I have to assume it's their lab. I don't really know. So I mean, I handed it to them, but they ripped off the name off the top. So I have a CBC or I have a CT scan, and so is has whatever. So it makes practice challenging. So you have to be creative. We try to find out about past treatments that patients have, what's ongoing, what's proposed. One of the things that often is patients will come and consult us about, this has been proposed or that has been proposed. What do you think about this, doc? Is this appropriate? Is this what you would do? Which means that you have to have some knowledge. Even though I'm not an oncologist, I have to have some knowledge about the various therapies that are offered. What are the odds of the success and what does the research show? So this has forced me to do a tremendous amount of reading. I advise the patients, here's what I would consider, but they have to make the decision. They have to make the decision. I know they want me to make the decision, but they have to make the decision of things. I like to do, if I'm going to do the IVCs, I will order a CBC, which I can do in Ontario, but the patients have to pay, and I will order a G6PD test for patients, and we will order creatinine. Now, the labs in Ontario offer creatinine and EGFR. Originally it was creatinine, then they did EGFR only, and now they're putting both numbers back on the lab reports. So I just like creatinine. Okay, so at the IVs that we offer at the teaching clinic, typically that we use a 24-gauge angiocath. The drips run for about 2 to 4 hours. They're typically done in a 500 ml bag containing 50 to about 75 grams of vitamin C. Our policy at the teaching clinic is that if we don't have a G6PD on a patient, we will do an IV of somewhere between 15 and 25 grams until we have that value, and that's the maximum that we will go for, just to prevent any problems. So that will typically be delivered in a 250 ml bag of sterile water. That's how we do that. Often added, now this is fairly routine for patients. There are some variations, but there will be some calcium gluconate, either mag chloride or mag sulf in a range of 1 to 2 grams, typically zinc, selenium, B100, B complex, which is a complex of several B vitamins, B6, B12 is often added. A lot of times this is given intramuscularly as well, and they will often add sodium bicarb to the solution. The IVs that I use in my practice, I also use a 24 gauge angiocath. They typically take 2 to 3 hours, maybe a little bit more in some individuals. And the range that I do once I have the results is I start patients at around 25 grams, and I will stay there unless I have the G6PD on those patients. But I will put 25 to 50 grams in a 250 ml sterile water, or once I go up to 50 to 100 grams, then I will put that in a 500 ml sterile water bag, and we'll deliver those over several hours. I typically add magnesium to most of the IVs, anywhere from 1 to 2 grams. B complex, I have done yes and I have done no, and I'm thinking about no now. I'm not sure. I have some mixed feelings about this. But Dr. Gaby taught me all bags should be yellow. That was his rule. All bags and all IVs should be yellow. So I must admit, the first person I treated never had any Bs in there. I just said, we're going to do vitamin C. I've added some Bs, and now I have some questions about Bs. I do usually put B6 in there because it is a cofactor of magnesium. The magnesium I have in there because it helps with patients' energy, ATP production, and these patients come and they're fatigued. And sometimes they're anxious, and magnesium is good for that too. And the B6 being a cofactor, I will put in as much as 300 milligrams in a bag. I have never had an issue with peripheral neuropathy. Never had an issue with that. I add B5 as much as up to 2 grams, again because B5 is an important cofactor for vitamin C, and it helps with energy. And so those are the big reasons I do it. And if somebody's had some bowel cancer, constipation, or something like that, then B5 can be quite useful. So Dexpan often goes into these IVs. So that's sort of my basic, but it will vary, as I say, from patient to patient. Now, some adjunctive things that I may give primarily intravenously, although they may or may not be in that bag, are selenium. And I've just given you some references about selenium and so forth. B12 in the methyl form, anywhere from 1 to 5 milligrams. Often what I actually do with the B12 is once I've established the IVC line, is then I will close it off and I will push the B12. And I primarily use this where there are issues with platelets or issues with low blood counts. It seems to have some bearing on that, and so that's primarily why I do that. Davis Lansom some years ago gave a talk at the AAMP about HCl, and you can contact the Torrance company the Torrance IV company in Torrance, Michigan, or Grand Rapids, Michigan, rather, and you can get free, as a doctor, 3 years of HCl therapy, which is worth reading. Guy Ferguson and one other doctor talk about their experiences using hydrochloric acid in a 1 to 500 and a 1 to 1,000 before there were antibiotics. So this is in the 20s and the 30s and the late 1900s, or early 1900s, and this was in Appalachia, which is that part of the U.S. which is very rural and very poor, and this was their main treatment. And they tried it for everything. The difference in the way they give this, just think about this, for those of you who had HCl, is they gave it intramuscularly. And they gave 5 to 10 mils, undiluted intramuscularly. I've tried a little bit of that, and it's not exactly what I want to do on my patients, so I don't do that. I try things on myself first. I give it in an IV push, and our policy now requires that it has to be diluted with saline, so we have to give it with saline now. But Lamson pointed out that what he discovered was that this, when given, if you do a patient's blood, you look at the white counts, and then you give them a push of HCl and monitor their blood 24 hours later, is that this can, in a certain group of patients, will elevate their white counts, which in certain cancers can actually be very beneficial. And so then you can monitor that at 24 and 48 hours after the initial push. And this improvement in white count can actually be beneficial for these patients. And so I tend to use HCl in patients who have low counts. Most of my patients can't afford to do if they're going to do the IVs, to do the CBC before and then do it 24 hours later and do it 48 hours later. So I based it sort of on what Dr. Lamson found. But typically I will often do this. And so again, once the line is established, this I will push. I can bind these two things, can be combined or done separately. And HCl in Ontario, as I said, has to be given in sodium chloride. So I will push somewhere in the order of about 5 mils or so. Glutathione, I don't put it in with the IVC. A biochemist friend of mine told me that it probably is no longer going to be effective when it's with that. And so I do it separately, either as a slope diluted push in sodium chloride or in a separate bag. NAC is again something 100 to 500 milligrams, and there's some discussions around using N-acetylcysteine. Glycerizic acid, 10 to 50 milligrams, is quite interesting, and some interesting work from Japan on its use in hepatitis B and hepatitis C. And so I have done that with some patients as a push, separate either after the vitamin C or just as it's initially established, pushing the glycerizic acid 10 to 50 milligrams. Zinc, anywhere from 10 to 30 mils. Alpha-lipoic acid, anywhere from 200 to 600 milligrams. I know this sort of bends the medical mind, but even homeopathics. And there are a number of studies coming out demonstrating that homeopathics have some benefits to play in certain types of gliomas and other cancers, of breast and so forth. So I can give these to patients as a regular homeopathic. They also come available in an intravenous form, and I can just do it as a push, or I can give them intramuscularly. So I've been working with some of those for many years. At CCNM, because it's a teaching clinic and we are trying to give students a basic, we have probably a more uniform approach. In most of the patients get a fairly uniform approach, although if I were to refer a patient there or another doctor, we will get the protocol that we want. So that the protocol can be varied. But the solution that I showed you there for CCNM is fairly uniform for most patients. And my own practice, though, the approach is much more individual, but our goals are quite similar. We want to improve patients' outcome with respect to cancer. I like the term spontaneous remission. That's what we're after. And occasionally that happens. We want to improve the patient's energy and sleep. We want to improve their quality of life. We want to address the side effects that come with the cancer and the treatments they're giving. And commonly things that we see that need to be addressed are anemia, neuropathy, fatigue, various sores and lesions that develop either on the mucosa or external, insomnia, and pain. Those are the main things that we're trying to address there. So, what's next? Now, this is where my talk sort of diverges from things you don't have in your thing there. At the RSNC in the research department, based on what I've just showed you of the research that we've done, what we're going to do now is to try to get all the patients, assuming they consent, into our database so that we can follow up with the treatments and the outcomes on these patients. And we want to find out why they've chosen this, how they are finding the results, and impressions that they have about their treatment at CCNM. We are interested in the quality of life. We want to use a quality of life measure to see how they evaluate the quality of life before and subsequent to our treatment, looking at such things as energy, pain, sleep, the psychological state of the patient, and other factors that we isolate. So right now we have a research resident who is working on putting together this survey that we will use, and we're in the process of trying to train our clinicians to enter this into the database. So, one of the other things Rhonda asked me to talk about was a little bit about the role. So, one of the things that the literature demonstrates is that ascorbic acid status of ill patients is typically low. And so I just cite for you a few studies here. Shora's from '96 and Maitland's a little more recently, showing that many of our patients with cancer or with other health issues are deficient in vitamin C status. And certainly a review article in AltMed by Dr. Head, and this one by Waring and Gutt, pointed out that low vitamin A or low ascorbic acid status or intake is often commonly associated with a variety of cancers. And these are the main ones where it's been studied. I'm sure it exists with others, but these are the ones where we have some supporting data. The question is, which is the chicken and which is the egg in this sort of thing? And that's a larger question. So, some theories about cancer. One is that, and this has sort of been the governing theory for a long time, is this somatic mutation theory, which goes back to the 1900s and has been modified more recently, which basically says that there is a genetic defect in an individual which leads to the development of cancer. The question exists, though, that this doesn't solve all of the problems. Why are we having such an increase in cancer in society compared to historically? It can't all be because we're living longer. And there are some other problems with this pointed out in this recent article, is that when tumors are introduced into animals, when they're used with a small filter, much different results when they're used with the large filter pores. Large filter pores, it seems that the cancers don't take, and with small filters it does. That doesn't quite make sense. And the issue here of transplantation can be successful when put into injured tissue, in other words, the cancer take, but when put back into proper healthy tissue, often it returns to normal. So these are some problems that are not explained by a genetic theory. So the other theory that has come up, the main theory that's come up, is the tissue organization field theory, which basically says that disruption of the basement membrane or the tissue is responsible for setting up a series of events that could lead to the formation of cancer. This supports the idea of the oncogene insofar as there is alteration of the supporting tissue or the stroma where the cancer develops. It is consistent with non-mutagenic carcinogens, field disruption, and long latency, and so that's one of the advantages of this theory over the previous theory. And then there's this older theory that doesn't get much attention. This is the collagen theory developed by a Canadian, W.J. McCormick, medical doctor, who practiced in Toronto, was actually fairly prolific. The problem with PubMed is it doesn't go back past about 1970 or 1980, and so unless you spend time in the library or look in current contents or old indices, you don't find this out. But McCormick published in 1954 his idea that the issue causing cancer was defects in collagen. That was his original idea. He even did some studies, and he got some patients to smoke. Can you imagine that, finding somebody in the 50s to smoke? But anyway, they agreed, no consent form required in those days, no IRB or anything. And he demonstrated that one cigarette reduced the ascorbic acid, he calculated, to be 25 milligrams in these patients. One cigarette. Now, if we take a pack of, 21 cigarettes in there, and do the math, that comes quite substantial. And he also published a number of papers on ascorbic acid in various diseases, whether it was deficient or as treatments. He used it, for example, in the treatment of polio, which was a problem in the 50s in Canada. So we sort of have these three theories to think about. But clearly the latter two are theories that are much more tied to our interest in vitamin C therapy. So why vitamin C? As an anti-cancer therapy, we know that the idea of its production of hydrogen peroxide, and there are a number of studies which support that, so I won't, and I'm sorry if I don't have your favorite study on there, but it's too voluminous to do, but there are certainly a number of studies that suggest this idea. And certainly going back to Klenner in '49, who'd been a colleague of McCormick with looking at polio and viral diseases. There's the issue of collagen disruption. One of the very interesting papers by Pauling and Rath was that ascorbate was inversely correlated to lipoprotein A. In other words, where you have high ascorbate levels, you have low lipoprotein A, and if you have high lipo-A, you have low ascorbate levels. And you have more collagen when you have more ascorbic acid present. So the body is able to form more collagen. Again, getting at the idea of this basement membrane or disturbance for causing cancers. And that's pretty much the same thing. This one was pretty interesting. I came across this study on tamoxifen because I was looking for things on lipoprotein A in cancer. It's not that well published about lipoprotein. And so this was a study that was done by a Harvard PhD showing that tamoxifen reduced lipoprotein A in women by about 40% within 1 month at the conventional doses. And it was stable over that period of time in 5-6 of those women. His conclusion was that maybe tamoxifen would be useful for treating high cholesterol, and we wouldn't have to rely on niacin if statin failed. That was his conclusion. That was his conclusion. He was not, I don't know, different approach. In trying to look at this lipo-A, this was a review article that looked, a recent one looking at about 530 patients newly diagnosed with cancer, so they'd had no treatments. There were new diagnosis, laboratory studies were done looking at this issue, and said that in general, most of these patients had low LDLs, low HDLs, and elevated triglycerides. And then, of course, the work by Peterovsky looking at ascorbic acid deficiencies and low collagen issues in that. Then we have the issue, as Ron mentioned earlier, about antiangiogenesis and the number of studies supporting this, that cancer has, in fact, a profound antiangiogenesis effect. And so I probably haven't got everybody's favorite paper on there, but again, I've tried to pick up a few of them. This one is quite interesting. They were just looking at cornea repair and noticed that when vitamin C was given, they got very poor repair because of the presence of ascorbate. So actually giving ascorbate after that was not a good idea in order to create new blood vessels. And then the issue of quality of life. There's actually very few studies in this area. Probably the best one is this study right here, a recent study by Yong and group from Korea. But in the original Cameron and Pauling studies from 1979, what they showed was that giving vitamin C enhanced lymphocyte and phagocytosis. It increased lymphocyte numbers. In my practice, what I try to do is I do this with vitamin C, and I also do it with the hydrochloric acid based on the work of Lamson and the earlier work by Ferguson and Guy. But they showed that both of those activities were enhanced by vitamin C, and this is not high doses. They're not in the doses that I was at. They're at 10 grams. They're at 10 grams. They showed that ascorbic acid versus non-ascorbic acid, doing various different calculations, their patients lived an average of 321 or 251 days longer. So we're talking here about 8 to 10 months longer, which is interesting because that's about the average time our patients are at the CCNM clinic. Now, I don't know if that means they expire at that point. I don't have the data to confirm that, but it is interesting that the length of time of visits. Several studies done in Japan showed that survival was anywhere from about 100 to 200 days more with ascorbic acid. And this particular study showed a reduction in viral load and a decrease in sin. This was in cervical cancer, just looking at cervical cancer using ascorbic acid and quality of life. And then this study from Korea showed that in the patients who received vitamin C, there was significant improvement in all of these factors: global health, physical strength and well-being, emotional well-being, cognitive function, social interaction, fatigue, nausea and vomiting, pain, sleep, and appetite. All of these things improved statistically significantly. The only ones that didn't improve were dyspnea, constipation, we'll have to get them to take more oral vitamin C, I guess, diarrhea, which is actually probably not a good thing with vitamin C, and financial impact. That was the one that improved the least, actually. That had the poorest. And you have to pay for services, you have to pay for services. But definitely quality of life, if you do a PubMed search, there's virtually very little that actually comes up about this. And so this is something that's new. So I think that suggests that the study we're looking at doing at CCNM is important to do. So what are some research needs and opportunities? What I tried to do was to sort some of these things out. I think there is still need to do more work on looking at the hydrogen peroxide and trying to quantify that in some way with patients. What are some direct or indirect measurements we can do which will quantify the hydrogen peroxide levels? And then what levels do we need for what types of cancers? Is prostate cancer need a different level than breast, than say lymphoma, than say colon, that sort of thing? Clearly, I think there's a lot more opportunity to look at this collagen and lipo-A issue and ascorbate in cancer patients. Rath and Pauling came up with the idea that probably there was a relationship there. They demonstrated it with respect to cardiovascular disease and diabetes and proposed it in a few sentences in cancer, but the literature would suggest that there is more that needs to be looked in that. The antiangiogenesis has definitely been demonstrated in some laboratory studies, and now it would be good to demonstrate it in more individual patients to actually show this antiangiogenesis. Most of it is in animals, most of it is in tissue culture, and we need to look at that within patients. The quality of life, as I said, there's really very little literature. If you type in vitamin C and quality of life on PubMed, you get 1 or 2 studies. That's it. You have to sort of read the other studies to infer from that, but quality of life is not something that comes up. And yet patients repeatedly talk about, my patients, and I see this at the clinic, how are you after your vitamin C? I may be tired the next day, and then for a week, 4 or 5 days, I have tremendous energy. I feel good. It's starting to flag. I need to come back here and get another IV. And so there is definitely something going on with the vitamin C and the other nutrients they were putting into that. They like that. They sleep better. They're able to do more things. They can handle their chemotherapy much better. I'll do it before the chemo or right after the chemo, and they can handle the chemotherapy much better and still come out with a positive result. Probably related to the collagen and other things are looking at ascorbic acid, lysine, proline. There have been studies looking at ascorbic acid, lysine, proline, arginine, various amino acids, EG-CG as combinations. Again, kind of like what I'm doing in practice and what we're doing at the teaching clinic in practice as they affect ascorbic acid and as they affect patient outcomes. So all of these factors that relate to basement membrane, that relate to tissue healing are important things to look at. This is a big one. The role of ascorbic acid in conventional treatment. Basically, to the doctors where I practice, the MDs, it doesn't exist, I don't do it, and they tell the patients not to do it. And a lot of patients, frankly, have to lie to their doctors about that, that they're not taking supplements. I've even had doctors tell patients, no green vegetables because of this, because that contains it. What they feed them is Ensure. Are you familiar with that down here? Yeah, which is just absolute crap as far as I'm concerned. They feed them Ensure and they tell them go out and you need to gain weight. So eat ice cream and eat butter and eat fat and all these useful nutritional things. That's what they want. They're just looking at pounds, not looking at quality. So there is definitely a role to that, and finding some cooperators to look at. There are definitely some studies suggesting that patients who do this it can be beneficial, but we need this larger. And then certainly this role of ascorbic acid and adjunctive therapies. Which of the adjunctive therapies that I'm using, that you're using, that other colleagues who are not here are using, are important and can improve the quality of life in our patients? And should it be different for different types of cancers? I mean, I think it probably should be, but I'm not really sure. I need to sort all of that out in my head, and I haven't done that yet. But that's something that we have to look at, is this role of adjunctive therapy. And then following up on the theory thing, when I read those papers is, and these authors call for it, so I'm not the first to say it, is that NIH and NCI, National Institutes of Health and National Cancer Institute, really need to look at a funding shift away from the DNA model of cancer to looking at other methods, the field theory, the disruption of the local terrain as it affects the formation of cancer, and spending more money on that. Virtually very little NIH, very little NCI money is spent on these areas. And so what happens is, if you're not looking for it, you won't find it. And so these are some areas that I would suggest where some funding could be done. And then this would, of course, tie in with what is the role of collagen, which is an indirect way of getting at vitamin C with respect to cancer. So those are some areas that I thought. So in summary, what I've tried to tell you is a little bit about naturopathic doctors in Canada, what we're doing with respect to treatment, what we're doing at the Canadian College, where we're training the next generation of naturopathic doctors who will be seeing patients, and some of them will be focusing on cancer patients or patients who have cancer in their practice. A little bit of what I do in my practice, a little bit of some of the adjunctive therapies that we are doing, both oral and intravenous, with our patients who are receiving these treatments. And then some ideas on the role of vitamin C, the various ongoing theories on cancer, why vitamin C, and some research needs and opportunities. Thank you.